Welcome, and thank you for joining us for this journal club on amplifying the patient voice, key priorities and opportunities for improved transplant and living donor advocacy and outcomes during COVID-19 and beyond. This journal club is a collaboration of the AST Advanced Practice Providers, Psychosocial Ethics, and Transplant Administration and Quality Management Communities of Practice. To begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded, and the archive will be available on the AVCOP, PSECOP, and TxAQM COP hubs and on AST's YouTube channel. Please note that your lines have all been muted so that only the presenters can be heard for the archived recording. If you have a question for our panelists during the journal club, we encourage you to participate by using the questions section, the questions and answers section in the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat section may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline, or we will post the full question with the recordings on the hub following the journal club. Finally, when you log off at the conclusion of today's journal club, you will see a link to a brief survey to complete. I will now turn the session over to our moderator, Hazel Domingo, to begin our presentation.
Good afternoon. My name is Hazel Domingo. I'm a PA at Northwestern Medicine and will be your moderator today. On behalf of the Advanced Practice Provider, Psychosocial and Ethics, and Transplant Administration Committees of Practice, I would like to thank you for joining us for today's journal club. The title of today's paper is Amplifying the Patient Voice, Key Priorities and Opportunities for Improved Transplant and Living Advocacy and Outcomes during COVID-19 and Beyond. It is now my pleasure to thank and introduce our speakers and hear more about their very important work on patient-oriented research. Dr. Amy Waterman is the Division Chief for Patient Engagement and Diversity for the Center for Outcomes Research at the Houston Methodist Research Institute, the Director of Patient Engagement, Equity, and Education for the Department of Surgery at Houston Methodist Hospital, and an affiliate faculty member of the TxAQM Research Institute. She also leads the Patient Engagement and Research Lab at Houston Methodist. Dr. Waterman's research examines how best to expand access to transplant, reduce racial disparities in transplant, ensure informed decision-making, ensure transplant adherence, promote paired donation, and increase living donation rates. Her research priorities incorporates many components of clinical and translational research, including patient-oriented research, clinical trials, behavioral studies, development of new educational technologies, cost-effectiveness analysis, outcomes and health services research, and implementation of best practices. Dr. Waterman collaborates with and mentors other researchers in nephrology, urology, health services research, economics, public health, and nursing with expertise and interest in transplantation or education research. In 2009, she founded the nonprofit suite of educational programs and trainings called Explore Transplant and Explore Living Donation, which enable transplant and living donation education to reach more individuals. Thank you, Dr. Waterman, for joining us today. Our next speaker is Dr. Devin Peipert. He is an assistant professor at the Northwestern University Feinberg School of Medicine, Department of Medical Social Sciences, where he is an investigator and psychometrician focusing on the application of patient-reported outcomes in patient-focused drug development and in clinical monitoring to optimize patient management. In this capacity, he works extensively on establishing evidence to qualify PROs, or patient-reported outcomes, as clinical outcome assessments to implement in drug trials. He also has a significant line of research examining new tools and methods to quantify and manage drug intolerability across multiple therapeutic areas, including oncology and solid organ transplantation. He's the quantitative lead of the Northwestern University Center on Outcomes Research and Education, where he heads efforts around study design and statistical and psychometric analysis. Finally, today, especially, we have the special privilege of having Mr. Jim Gleason, the president of Transplant Recipients International Organization and a heart transplant recipient.
Wonderful. Can everyone hear me okay? Great. So I'm so honored to be here and representing this really distinguished panel and diverse panel, which is, I think, what we're all standing for as we listen today. And we don't, let me see, make sure I can drive. We don't have any conflict of interest disclosures. And with the paper that we're going to talk about is one of my favorite papers in a very interesting way. So this is the first paper I ever did as an investigator where many of my co-authors are patients. So Jim Gleason is representing, our journal club today, but Louise and Alexander and different people on this came forward and said, we agree with what you're thinking in terms of how to amplify the patient voice. We suggest more improvements. We think this is comprehensive. So what I really want to say right from the get-go of this journal club is that this is fundamentally an example of how we are trying to amplify the patient voice. And by having Jim here sharing more of his experiences, I think that we'll all benefit. So what we're going to do today is we're going to talk about some key definitions to orient all of us that relate to this paper. We're going to discuss some key recommendations from the article, but I'm a practical sort. I don't know about you guys, but I am working in a hospital every day. I am trying to do best by our patients. And there's a part of me that says, well, I already do pretty well, right? Like, and I want to say I have a guess that everybody on this call are doing amazing things to include patients. So it's really a sense here of what can we add to what we're doing, what new innovations might be helpful, and let's all grow together a little bit in this hour. So what I would ask, if you'd be generous enough, is for you to put some sharing in the chat or just offer to share, because I think that this is going to be much more valuable than if I just lecture at you with a slide deck about an article, right? My sense is we need to really use this as a moment to check in with each other. So let's start with an interesting question, and I'd ask my co-panelists here to help kick us off. So our title of this article is Amplifying the Patient Voice, Key Priorities and Opportunities for Improving Transplant and Living Donor Advocacy and Outcomes. So why did we name it that? Who cares about amplifying the patient voice? I'm wondering if my partner Jim here might get us started. What do you think? Do we need to amplify the patient voice? Is it useful? How?
Definitely does. And when you engage the patient in what's going on and allow them to have a voice in the whole community besides, you have a much more successful result of an organ transplant, for example, or any other medical condition, as opposed to they're off on the side and the medical staff doing what they do. Mm-hmm. And so I am a strong believer that the patient should be the center of the committee, if you will. After all, it is their life. And it's an important voice, and I think in the recent years I've seen more of a switch to recognition of that voice. I've been an ongoing member at Penn Medicine here in Philadelphia on a patient family advisory council, and more I see centers building these opportunities for patients to speak out and be engaged in what the hospital is doing in so many different ways, and so many things that the medical staff are doing. And they find out, oh, I can have a patient come in and we're trying to do it for the patient. But too often they don't ask the patient, by the way, what do you need? And what do you think about what we're trying to do? Bring that voice in and you got quite an exciting thing going on.
That's great. Devin?
Yeah, well, I mean, I think Jim said a lot there to kind of just to add to that. I think patients have a lot of expertise that no other stakeholder in the process does. They can tell us things not only about their experience with the care process, but about their own health. They can report on aspects of their health that we can't learn about in any other way. So making sure we amplify that voice in various ways, not only is the right thing to do by including someone who's most impacted, but also is the way we do the best science and provide the best care.
I'd agree. The other piece for me thinking clinically is that there are things in our blind spots, right? That by, we live it, we try to provide the best care. There are things in our blind spots, and I feel that the patients can point those out if we can slow enough to listen and to learn. Okay, the other piece about why I'm very passionate about this is we're not that successful. There was a study that came out before we go into this journal article by Jesse Schold and colleagues, and it basically said in the last 2 decades, we've not advanced kidney transplantation. It's actually worsened in terms of vulnerable populations. And we've also found that in terms of looking at trends in access to living donation, it's getting worse, and national strategies should be revisited. So the piece for me, if you think about a patient voice, is we're missing something, especially for our diverse patient communities. And the data is showing that over and over now. And what we're doing is not yet enough. So I want to talk about these key definitions. So the first one, what is patient engagement? We talk about it, and in looking at this, the article speaks to this. It's the capacity for patients to actively choose to participate in a way uniquely appropriate to them in cooperation with a healthcare provider or institution. So they're choosing to be our partners. The other part is in terms of advocacy for patients, it's about the whole patient. We're focusing on health and wellness, not on just treating diseases and having an outcome called the patient is alive, the patient got a transplant, and it's working. So there's also a sense of patients having the value, the right to decide what's right for them, even if that might be not always recommended by a certain particular healthcare professional, and not pressure them into doing something else. And the takeaway of all of this is that if we have engaged in advocating patients that are speaking up, then we can really know how best to serve their needs. And none of this is a surprise. I'm a social psychologist, and this makes immediate sense of where I come from as a provider. But what's exciting is when it leads to patient activation. So if we're all honoring a patient, allowing them to choose, the key message right now in our field is that we need to have patients who can activate and to partner with us for more successful outcomes. And if they have the knowledge, skills, and confidence that they can do that, the chance of their experience being better as a whole will be more positive, but also things that we've always cared about will also be there. And just to give you an example of a patient activation measure, this is an example of a measure that's now being linked to reimbursement for dialysis care. And I just wanted to kind of show you, because to me, when you look at the measurement, it makes it really real, right? You can say patient engagement, patient activation. But then if you look at these measures, do you feel your patients know what each of their prescribed medications do? Or are they confident that they can follow through on medical treatments they need to do at home? Or do they understand the nature and causes of their health conditions? Then to me, this immediately has me start thinking as a clinician that, maybe there's a gap here. Who has a gap here? Where are our systems slightly not set up to provide somebody to be able to answer this question confidently? So talking about the dialysis care for a second, here's an example of a paper that just came out talking about how if you look at patient activation measures being built into care, and we can do this the same in transplant as well, you can see that various measures of a patient start and link to the successful taking of healthy behaviors and their shared decision-making on treatments and ultimately their outcomes. So patient-centered care, which is what all of this is we're shifting now so that we're looking into the value-based care, which looks at all of the dimensions of care at once. So I think this has been very exciting. Devin, would you like to say anything about how what you're seeing about other areas and how it's now coming into transplant, to give us a history?
Of patient activation in particular?
We can keep going. I don't know if you can go ahead and speak about this. Maybe I'll drive for you and you can add anything you'd like to add.
Sure. Well, I think that's a nice segue, Amy. I mean, so patient activation in that particular measure, I think, it's really exciting to see that coming more into the kidney space altogether. I think it's one of the characteristics that we can capture about a patient to understand how likely they are to, as Amy just said, move forward with key sort of health behaviors, takes particular steps in their care process to ultimately gain access and use better quality care. And that brings us to, well, are we really capturing everything like patient activation and other concepts that really are most important for telling us about the patient's experience, sort of their attitudes, their knowledge, as well as how they perceive their health. And so this gets us to my particular expertise, which is in patient-reported outcome. And I'm going to just give a standard definition for a patient-reported outcome, which is any report coming from patients about a health condition and its treatment without interpretation of the patient's response by a clinician or anyone else. And in general, when we think of patient-reported outcomes, we're really talking about patient-reported health, which is to say, we're not talking about, is the patient satisfied with their care? That's important too. Did the patient appreciate, the services they got? That's great too. But to kind of start with, we're talking about key aspects of the patient's health that they are telling us about versus a biomarker or a laboratory test or something else. We have here in this bubble some examples: physical function, pain, emotional distress like depression, anxiety, sleep, fatigue, ability to go out and participate in your everyday social roles and activities. And, again, another way of looking at pain. These are core sort of areas of concern for transplant recipients and those seeking transplants. And the best way to understand these is to ask people how they're experiencing them. That's not the only thing that we can capture through patient report. Although they're not outcomes of care specifically, we can also learn about key health behaviors like medication adherence, what the patient's treatment priorities and factoring, their sort of thinking around their decisions for around which treatment they would like to pursue. All of this comes into a strategy for learning about the patient's health and how they're going to interact with the services that we may provide them by capturing their voice through patient-reported measurement. Go ahead.
And if I could ask a quick question to Jim, when you see this, Jim, any thoughts about kind of from a patient perspective about these kind of dimensions of your experience as a patient being captured? What do you think about seeing this, that we're talking about, should we be measuring all of these things too?
I think so. There's so much uniqueness to each individual patient. And the only way you're going to really give the correct treatment to a patient is by understanding who that patient is. Mm-hmm. And I can still recall, it was 28 years ago when I got my heart transplant here at Penn. And I was in the hospital probably about 7 days after the heart transplant. And I knew I had to get out of there. And as the doctors were doing their rounding, I went and got them and I said, I need to talk to you because I can tell you what's going on beyond what your blood work and other tests can tell you. And I'm telling you as a patient right now, I need to get out of here before I get sick from being in the hospital. Mm-hmm. And they were very respectful of that, which I really loved about my team. And so that whole concept of teamwork and listening to the patient can be so critical to the successful outcome that we're all trying to achieve.
Mm-hmm. Thank you. Thanks so much.
Yeah, this slide just kind of helps make the points we were talking about previously more concrete, giving an example of a way a particular patient-reported outcome has shown up in the literature recently. I think assessment of physical performance in the context of kidney transplant is a really key issue to kind of drill down on one of them now. We know that things like frailty and your sort of fitness for transplant really matter for the outcome at the end of the day. We've tended to sort of do that type of assessment through performance tests that must be done in the transplant clinic and are more time consuming and frankly more expensive. And one of the nice things about sort of asking people and sort of using patient-reported measurement, in addition to being the right thing to do, is that it's often fairly convenient if you take into consideration the burden on the patient side and not give them too many questions too frequently. But now being in this sort of COVID world, we've really sped up our ability to do sort of e-health, and along with that has come opportunities to send short questionnaires to folks and get their responses. And people like me who are measurement scientists are working all the time to figure out, well, how can we do that in a way that's convenient for folks, that doesn't take too much time and kind of fits in with their daily life. And so you can imagine a scenario where we sort of learn about, hey, in terms of your physical health, are you really ready for the transplant, or what can we do to bring you to the point that you are, to make sure that we really give you the best transplant experience that you can. That's just an example. Here's another one that gets to some work that Amy and I have been partnering on through a very exciting grant she got some time ago, looking at the experience and sort of clinical pathway that potential living donors take when they volunteer for donation, where we've been able to dig into what's the role of anxiety in that decision-making process. And here's an abstract that we've recently submitted around this. Again, I won't get into too much in the weeds here, but what we're learning is that the level of anxiety, as you expect, really has a lot to do with how likely someone is to go on and decide to donate, and how well they're able to navigate the process of that decision. These are things that are modifiable and that we can provide help around. They've often been considered sort of supplementary or tertiary services, but there are ways that we know how to support people in and could make a difference on a variety of levels. So that's where we're looking.
That's great. This, just to kind of add a little bit more, this is an example from Mayo. We heard a talk with Mayo, but the idea is providers can have dashboards of these kind of measures, these patient-reported outcome measures, where you can track a patient's change over time. So if you're having a patient who gets a transplant, now they're recovering, they've gone home, and now it's 6 months later, you can look at, are they shifting on any of these in the exact same ways all of the other outcomes that you're tracking. It also, I know that because these are outcomes that are normalized. Devin, my question for you is, can somebody say this patient's having a lot more pain or a lot more anxiety than other people at this point in their journey?
Yeah, I mean, so a couple things there. I mean, one is that in general, with some of the advances in health measurement, especially using the PROMIS system, which was, I'm not going to sort of get into all the details of that, but the NIH has invested very heavily in the past 10, 15 years in creating a set of patient-reported outcome measures that everyone can use and that are really referenced to the general population, so you can make easy comparisons and say, compared to the average person. Now, that's a starting place and really a great starting place. But, I think we need more research like this in transplant to make some of the kind of comparisons that you're talking about, Amy, where, what's your experience as a patient compared to the person who's typically going through this, or the average patient going through this. I don't think we do know that in transplant yet, but we're learning through our research that, is highly inclusive of patients, of course.
Great. So thank you guys very much. Okay, so going back to the journal article, and I just wanted to ground you on some of the key definitions, because then that'll make this part for the recommendations more helpful. So basically, the journal article recommends that we do three main things: that we need to include the patient voice in healthcare decision-making, that we ensure equitable access to the best treatments, and we honor the priorities of patients in innovations and policies. So I want to talk a little bit about that. And to do that, I want to actually distinguish this in terms of the multi-level intervention framework. So we have a patient in the middle, and we often say to engage a patient, we need to focus on the patient, right? Like we need to get them engaged. But the key here is there's a lot of points of intervention in which we can be intervening on to make this process more engaging and to connect with patients and to facilitate this and to work with their families. And if you don't think along this whole pattern, you're going to be really putting a lot of pressure on patients to be able, to take responsibility for more, and for us not to kind of own the parts that we can change as well. So I guess what I'd like to do is have our first chat moment. If if you all could maybe just take a second and look and say, you know, what kind of barriers are you seeing that might be reducing patient engagement and advocacy at your institution? I'd really appreciate it. So let's just take a second and put this in the chat. And if you're willing to share, God bless you, open your thing and talk to me. I'm not scary, but it's okay if you don't. So let's see if anybody are willing to share here. And maybe we'll start, Jim, do you wanna like be my panel here can be talking while we're getting some chatting going on. What do you see are barriers that reduce engagement and advocacy? And maybe through TRIO, Jim, you could share a little bit about that.
Oh, the first thing I thought of was language. I mean, there is a layman's understanding of language, and in the medical staff side, it's natural to use it because that's the community you're working in. But when you're dealing with a patient, it's very important for them to understand. And quite often a patient won't challenge or ask questions because they feel kind of stupid in the environment of, let's say, a team rounding in front of them at the bedside, as one example. And as a result, you miss the opportunity to get them engaged. And I recently was reading a book, and it was a 9-year-old who was really helping a community come together. And every time somebody was talking to her, she said, "No, there you go again. What did you mean?" And she constantly made them honest. And I think we have a lot of difference if we were equally honest with our patients, and you have to listen to them because they may not be courageous enough to challenge you, to ask you. But if you say, now you confirm what you think you just communicated with them by asking for their feedback, you can bring them out when they may be reluctant. Just one idea.
Yep. Hazel, do you want to read the kind of comments coming in?
Yes, we have multiple answers, and some of them Jim had actually alluded to. Somebody said the patient might be overwhelmed with medical information. They might feel intimidated. They don't know what they don't know. Mistrust of the healthcare system. I personally, in my practice, also see this, particularly during the age of misinformation, and as well as time. So lack of time, possibly during the clinic visit, or perhaps just, you know, with the stresses of the pandemic on their personal lives and not having enough time.
Great. Fabulous. All good answers and definite challenges. Now, what about some of the other circles? Do you see there's provider challenges or family challenges? What about organizational challenges? Does anything come up that are part of our side of the care delivery process that come to mind? Devin, any ideas you have from your work?
Well, I mean, I think, you know, there are the organizations are trying to adapt fast to help sort of make some of these touch points and listening to patients more fluid. But with that comes a lot of, you know, I would say, you know, stumbling blocks. You know, it's hard to reach all the patients we want to reach. So, you know, we've made my chart available and said, please tell us if you're experiencing something wrong, but who really has access to that? Who's willing to use it? Does it require sort of engaging in a way that is unfamiliar or uncomfortable? And do we really know how to make that comfortable and familiar to everyone? Can we actually exacerbate disparities by sort of coming up with new ways for sort of patients who are already starting off the best to engage? And so I would say some of those are the barriers that as we jump in, you know, the organizations are sort of, you got to start somewhere, but you know, to be honest, you know, where the rubber meets the road, you don't really know how to do it until you start trying to do it. And there's a lot to learn.
Yes, very well said. So Hazel, you want to keep reading?
Yes, we also have a comment about impersonality of care provided to patients. Although there's a comment saying virtual screenings seem helpful to some. Personally, also as a provider, I would say there's also a lack of time and even access to care, especially during the pandemic. A lot of clinics have closed, and we may not always reach all the patients, and therefore it's difficult to engage them during the time of the pandemic.
Yep. Yeah.
Amy, if I could, the other aspect of, you know, the COVID has really forced us to do things that are way overdue, and the use of technology. And you think of time barriers that somebody mentioned, for example, getting and looking at some of the other barrier levels here. I think of the family, for example. I'm not sure where they fit in your diagram here, but they should be there. And, you know, the caregivers, especially when you're in the hospital, want to be there and hear the doctor personally. But again, the rounding takes place when they can. They've got a lot of patients to see. But today, you have the opportunity to have that Zoom technology in the patient room, and you can schedule the family to be there in a way that they couldn't if they were distant family, for example, or even family that are local, but aren't going to be there at a 7 o'clock rounding, for example. And they have careers and work too. So there's a lot of opportunity afforded by the technology. And I think we're slowly learning that. My fear is we're going to drop some of that learned technology as we get back to whatever we call normal. And that would be a shame.
Yes, no, that's great. Love it. All right, great brainstorming from everyone. Thank you so much for your participation so that this can be valuable for you. So let's look at what the article said and think about it. We've said some of these, and let's see what else we can add to what we've talked about. Okay, so in looking at some patient level in the center of the circle, what the article speaks about is, okay, there's challenges with education. This is big. Like if you ask me, the majority of the recommendations of this article deal with the fact that we have trouble communicating, educating, delivering, and making sure someone learns something such that they will have better care, right? And there are probably an infinite number of things we could talk about just about education, but low health literacy is a big issue. People who have less access, period, to education. In the kidney space, we know that there's inconsistent education that has been made available if you're in earlier stages of CKD relating to transplant, so that people might not even know about it earlier. There could be patients who are having more medication side effects than others and could stop their medication. And then there's issues of finances. I don't know about you guys, but in looking at all these recommendations, the big edit that our patients on this article said was, make sure you are educating us about money and insurance and all of the pieces of this. You guys give us the medical stuff, but you kind of gloss over the stuff that we see intimately, and it affects us going forward. So the recommendations from the article from the team were, the first part, we talked about time. And it's funny, I feel like a takeaway from this article is that we need to ask a lot more questions and we need to listen a lot more than we do, right? And that is it's the impossible, challenge of the limited healthcare time that we have. But how in your practice can you pause for a beat and say, okay, what do you want to say back, teach back what I just said? Let's just confirm that you got it. Also, the other piece for me as a long-term educator is that I don't believe you can give anyone a binder of information and pretty much ever expect they're going to learn it. How do we take our really important educational content and make it in 6th grade reading level or less and provide it over time and repeat it being provided? I think that we often say, well, we gave them something. Yes, you did at a different point, and now it's time to read it and learn it again. So think about how your delivery of information can be spread out and repeated in smaller increments. The other part I'd say is that we're doing a lot. I'm here working on DEI initiatives. I'm sure this is happening around the country. And the key thing is where we actually coded our entire process to see where do we have where at every point are we connecting with patients? Do we have education in multiple languages? Do we have access to somebody who speaks that language? We're also doing implicit bias training, things like that. That's coming up. In terms of medication side effects, Devin, do you want to speak about kind of what you see if patients are priming for that?
Yeah, I really do. So this is one where, and this allows me to get on my soapbox a little bit. I think, I was sort of raised in transplant as a sort of a staff member and trainee of Amy's, and then now, I'm sort of been lucky to be around transplant for a long time. And part of what I learned during that time was that, we're sort of living in a paradigm where, especially in kidney transplantation, the goal was to say, hey, we're going to get you to transplant. When you get a transplant, you sort of won, right? That's great, especially compared to dialysis. And without taking anything away from that, I think we also need to modify that paradigm so that we say there's a lot that now that you've won, and we've got to sort of work with you to help sort of figure out how to maximize the benefits of that transplant for as long as possible, right? And part of that is making sure we have ways to deal with the medication side effects that you are very likely now dealing with. And while you're grateful for the transplant, it's okay to say, hey, this tremor or whatever's interfering in my life. There's a quick anecdote that I heard very recently that I think it sort of makes the point in transplantation as well as any research or numbers could, which is that there's a very well-known transplant surgeon who is also an organ transplant recipient, and his immunosuppression was causing his hands to tremor so severely that he could not perform transplant surgery anymore, which I think is just a nice way to kind of bring the point home around, you've got the transplant, but we want you to live well. That was the whole point of the transplant in the first place. And with the sort of very large patient-focused drug development enterprise that FDA is interested now, the goal is to say, how do we design medications that not only keep your transplant, but keep you feeling good and able to interact and participate in everything you need to do, and not just fun stuff, but like, can you go to work and can you sort of really do everything you need to do to maintain your life? And so for me, that's my goal, to help get us to that point.
That's great. Jim, anything you want to say about money, post-transplant financial planning? He's like, no, it's
I'm
terrible.
Sorry. After the transplant, it's too late. If you don't have insurance, God bless you. You have to have that up front. And, people who are off in environments where they aren't getting health insurance are taking the highest risk. That's worse than going down to Las Vegas, all right? When I look at what are being charged at the hospital level for 1 day stay, God only knows how, and what the insurance has agreed to on our behalf, and what our copay is, oh my God. I think of the poor slob that said, no, I'm not going to buy insurance because I'm young, I never get sick. And guess what? They hit by a car, they fall off a bike, anything happens to them, they get COVID, and all of a sudden they got to pay the big bill. They don't have the insurance company negotiation. And so it can be a breaker for an individual, for a family. And it's one of those things, it's a wise thing to do. And sometimes in our younger age, especially, we make an unwise decision of saying, we can't afford that. Well, my God, you can't afford not to have it. So financially, it's all upfront, I'm afraid.
Yeah, we love our financial coordinators. Yes, they are critical to the success of a transplant. We all know that. That's great.
Yeah.
So looking at family level recommendations, the kind of barriers that were named in the article were difficulty attending medical appointments. The Jim already said, expanded clinical hours, telehealth. Free childcare was one that I thought was a out of the box thought for me that I didn't think about, how do you get in families that could come if they could have their childcare covered. And then at home tests. After COVID, there was a big kind of blood test going to the home. And I think these are the kind of innovations that could continue. Then there's a lot of family members who were never invited to learn about living donation. We're seeing that at our center here. And the key is, how do we create opportunities for family members to be part of educational moments as well as care moments from the recipient, including through telehealth. And finally, a lack of understanding of the importance of the caregiver. I really want to credit the Psychosocial Committee because they've been building a caregiver toolkit to really say, how do we support caregivers better? And that's so critical. And often in our, saying, well, caregivers will just absorb the stress of this. But there's also social support worksheets that can be provided to patients and other kinds of resources, financial and otherwise, to make this journey a little bit easier. Excuse me. So for provider level recommendations, what we're seeing are providers earlier than us. Excuse me. So the key that I see happening in our field right now is we've got all these silos of care. And the point is, how are we reaching out to dialysis, to primary care, to people who might have our patient groups to make sure that transplant's not a surprise at the end of ESRD? The other part is, how do we reach the patients who've not yet come to us and the doctors who refer those patients? And how do we make it easier for doctors who might not have the knowledge that we have to disseminate that information to patients earlier? Are there other thoughts that anyone here has on the panel about provider level recommendations?
One of the concerns I've seen, and TRIO has been involved in looking for ways to help the patient post-transplant. And one of the issues we realized is there was a lack of focus and long-term awareness of the higher risk for cancers after you have a transplant, both because of the medications and also advancing age. And as we got into that, we realized when the patient is in the care of a transplant team, there's a focus on this. But when you have large programs, such as your kidney programs, where they turn the patient back either to a family doctor or even a kidney doctor, a nephrologist who's not familiar with transplant, that focus is lost. In other words, you as a transplant team, you're asking the right question. Are you seeing a dermatologist? Are you doing the right things, preventative things for post-transplant cancers, since you're living with the higher risk? But if they're referred back to somebody that's not on the transplant team itself, that's pretty it's a catch as catch can as to whether that family doctor or the nephrologist is going to focus on some of the issues that are unique to transplant, such as those cancers.
Great, love it. In terms of the external parts of the circle that we mentioned before, so I think this is, Jim's naming this powerfully, that you have a disjointed healthcare system and you lose patients to follow-up. So the key, I would say, is that if there's, when I arrived where I'm working now, I said, what do you have on post-transplant cancer, knowing that Jim has trained me well on this? And they said, oh, we have the 3 months right after transplant, we have after recovery, and then we don't have 10 years out. And so they were like, we'd really like, so TRIO has actually created a transplant cancer website. The other part is that kidney campaigns are happening a lot. There's starting to be better messaging in the community and better tailored messaging for people. And so I think there's kind of a sense now of not having transplant be only in transplant centers. So transplant and transplant care. The key is, how is this a normal thing? That it's in our community, we have it on TV, there's movies about it, there's television shows, and then there's, the public knows, yes, you can donate a kidney. And the other part I would say is, I did a study with colleagues many years ago, and we called diverse community members, so Black and Hispanic, the public, and we said, what are the important issues affecting your health? And they said diabetes and hypertension. So then the takeaway from the kidney community was, how can we link our kidney care in with diabetes and hypertension messaging, because they already see these and live with these, right? So we don't have to start with saying, what is your kidney and what does it do? It says, look, if you don't take care of your diabetes and your hypertension, what could happen are kidney challenges, but there's ways you can monitor your kidney health and hopefully prevent it from happening. So how do we weave in community messaging? So those are big recommendations. So I think we've said a lot of these in our group sharing, but the other part that I think that I'm left with is that mostly in the 20 years I've been working in healthcare here, the patient voice is not usually sitting at the panel. And I want to say some exceptions to that include, I was on the UNOS Living Donor Committee, and we had to have many living donors, both with good and bad outcomes, on that committee. So as you think about your leadership groups in your hospital and also in your committee membership, are there patients that represent both the successes and the challenges of transplant so that they can speak to what we need? Devin, do you want to say anything about clinical trials and what you're seeing with pros?
Yeah, of course. Well, so, as I mentioned earlier, in the past, 5 years and building, up to that over a lot of time before that, there's been sort of a push to, bring into the evaluation of new drugs, just not whether it sort of meets sort of what you might think of as the primary clinical outcomes. So say in the context of kidney transplant or other transplant, does it improve, graft survival or patient survival, which of course are very important. We don't want to lose sight of that. But in addition to that, what's the patient experience? There's actually some mandate now that, approved drugs need to be able to report on, how do patients do on this from their perspective, and some of the ways I talked about earlier, which includes sort of PROs, and particularly looking at side effects and tolerability. How are patients able to, is the drug toxic even though it might be effective? And so, as part of design of clinical trials now, we're pushing to have PROs included in every single clinical trial. So we don't know just about those primary clinical outcomes, but we know, does it improve patients' lives in other ways, or at least not harm patients in other ways?
Great. And then another one that I have seen happen that a lot of people are working on is we're capturing patient stories in new and innovative ways. So there's digital storytelling libraries. There are stories that are kind of coming out for people thinking about making decisions on whether they should do something. It's exciting to capture patients' voices directly as opposed to a whitewashed kind of ad for transplant, to have patients share what they think that they want people to know. Now, we've talked about education a lot. The key takeaways are health literate education in multiple languages in modular ways. There's a lot of systematized, centralized resource hubs that I think can be promoted that are on the UNOS website, the National Kidney Foundation website. And then finally, as Jim alluded to, how do we use technology most effectively? Technology gives the ability to have systematized education consistently provided in modular ways, so that's great. But then we also know that it takes a human touch, and we need to think about what we need to have conversations, back and forth communication. How can we do that in a cost-effective and a direct way? And then finally, Devin spoke about the outcomes important to patients. I think the big takeaway for me in working in patient-reported outcomes is that we need to be really going, what do patients care about? And I'm making my hands like this because it's like we've been saying, well, they care about being alive. Yes, of course they do. But there's a whole lot more in terms of caring about quality of life and freedom. And then again, the financial assistance and support, so that this is something that doesn't harm them financially by having hopefully the advantage of transplant. Would either of you like to say anything about any of these recommendations?
I think that the timeliness of good information is important, and it's different at different stages in a person's life, okay? When you're facing transplant, you're facing death, there's one priority: to be alive. Now, once you're alive, now I can complain about taking too many pills or the side effects of those pills, because I'm not concerned about being alive anymore. Now I'm concerned about quality of life in many other different ways. And so when you get information, like we found that, TRIO found that the patient's awareness of the higher risk for cancers in the years post-transplant. I mean, it's one thing to give that information up front when they're a candidate even. And at that point, their priority is such that they probably shake their head, yeah, okay, but they don't pay attention to it because it's not important yet. After it's over, you've got a period of instant recovery, and some of those issues come up quickly, but the higher risk doesn't kick in until years later, and with age and with longevity. And so how is that follow-up there in our post-transplant cancer website, TRIO web PTC, posttransplant-cancer.org. We've gathered that information in many different levels and in a logical format to make it available for the patient when they need it, okay? And they're not going to pay attention to it up front. But at some point in time, we're trying to give those transplant medical professionals the tools to give the patient what they need when they need it, and to guide them to this resource, which once you get in there, there's such a wealth of information that can complement what the program is trying to do to ensure the longevity and the healthy conditions of their patients. And so that partnership between the patient support organization, who's focused on the patient, and working with the transplant professionals in teaming up to help those patients live a long, healthy quality of life, is the whole goal that we all share. And so enabling that resource to be available when they need it is key. And that's where TRIO comes in, for example, and the team can now use it. And we're so pleased to have that kind of partnership.
That's great. Devin, anything else?
Yeah, it's hard to add anything on to that great summary, Jim. I mean, that you hit all the right points that I would like to say, but just from the standpoint of, we're currently sort of assessing the quality of transplant centers and whether or not the transplant worked, on whether someone is alive or not and how long, or if the graft worked or not and how long. And sort of, that's a big range of health if you're just alive, right? The person who can't get out of bed and the person who can run a marathon are both alive, but we want more out of it than that, right? And so at some point, I think we need to start thinking about how can we judge the performance of the transplant, the success of the transplant on some of the things Jim just sort of mentioned about, how well is someone functioning and what resources, and hopefully that would incentivize, disseminating resources for, hey, if you're not totally, doing, functioning well, you're not ambulatory, you're not out moving around, what kind of resources can we connect you with, rehabilitation, et cetera, that helps get, achieve that status and helps achieve sort of full restoration of health, along with managing side effects in the way that I mentioned previously, to make sure that, that there's really sort of realizing the promise of the transplant, I think, as opposed to just sort of saying, you got one and you're living, that's good enough for us.
Yeah.
Which I know that all transplant providers want more than that. It's just living in a system that's not communicating that in the way we want it to.
Well, you're touching an interesting point there. That is, we all want successful, but we don't know what successful is.
Mm-hmm.
And so unless you can measure something, how do you improve it? And so in the transplant world, for example, if you're in UNOS as an example, trying to measure the effectiveness of the various elements of the teams, is 1 year survival? Check the box. Yes, I'm alive. I'm still here. Success. Yeah, but if I'm not living a quality of life, maybe it's not so successful. So measuring it and knowing what to measure is the key challenge I think we have today.
So great.
And
Yeah,
so
love it.
You're hitting the good points.
I so love it. Okay, so I wanted to give a moment for our group, just if you took something away from this talk, because we're on all of these Zoom calls, they get tiring. What would you take away from here? And it doesn't even have to be a care change. Like, what's like a new thought you've had? Hopefully you've had some that people would be willing to share about kind of how we as a field could be expanding what we're already doing to have optimal patient advocacy, which was the focus of the Journal Club. If you could put your comments in the chat. Hazel, is there anything you've taken away while we're waiting for some chat comments?
Yes. I think we cannot overstate what Jim said most recently, that, just the fact of being alive at 1 year is not really a great measure of success. And it's, now that we are putting more emphasis on patient-reported outcomes, we really should partner with our patient and listen to them more about what's important to them. And like Jim also said, that's different for every patient. So now more than ever, it's very important to keep that line of communication open, so that not only are we feeling the success as the transplant center, but the patient as well.
Mm-hmm.
And while we're waiting for more comments, I do have a question. Is long-term survivorship programs within transplant centers and patient advocacy programs a bigger need, you think, than we think, especially as transplant continues to grow?
Mm-hmm. I'd like Jim to comment on your experience with the post-transplant cancer work. Do you think that the transplant centers need to connect long-term survivorship, kind of the idea that keeping people healthy, after being referred back to their other care providers?
I think that's key. I mean, again, being alive at the end of the first year is certainly critical. That's the foundation, but all it does is open up the door to the rest of the questions. How healthy are you? What are you doing? Are you able to do what you need to do? Mm-hmm. And TRIO, as an example, is a patient support organization, as a National Kidney Foundation, American Association of Kidney Patients. We all trying to help those patients in those expanded areas. Now that you're still alive post-transplant, okay, congratulations. But how about 5 years, 10 years, 15, 20 years, 25 years, or in my case, 28 years with a heart transplant? I mean, a lot of people will tell my wife when she shares that, it comes out in all sorts of conversation. They said, that's not possible.
You're not possible, Jim.
It's certainly beating the average, but she looks at them like, I just left them at home. Believe me, it is possible. And so it's a fun thing, but at the same time, it takes a lot to get there. And those transplant teams have a lot to play in the years beyond. And that relationship, let's face it, it's easier to have a relationship with some patients than others. It gets back to that uniqueness of the patient. What do they need? And in some cases, it's a lot easier to have that relationship, which gets a transplant center calling me the day after somebody saw me carrying a box of books for patients in the hospital up to the social worker's office. And I was out of breath.
Mhm.
Well, it was 50 pounds of books. Okay.
Yep.
And somebody saw that. I got reported. They called the house. I was out having lunch with the friends. They called me at the restaurant to make sure I was okay.
Oh,
Now that's
great.
extraordinary care. Okay.
Yeah, that
I
is.
brag on it. I brag on them all the time. But it's again, what each individual needs to satisfy that word of success
That's great.
post-transplant.
And as we wind up, I just want to say we can obviously hear from Jim how valuable hearing the real stories of patients are. And there's a resource publicly available called explorelivingdonation.org, where people who've been part of living donor transplants and living donors have shared their experiences to provide education for other people that might be valuable for some of you. Okay, I wanted to turn off the presentation to see if there were any questions from anybody in the group for our last time.
We have I believe it's more of a comment, but I guess we need to emphasize the importance of financial education and, bring up the point that just because you have insurance is not always enough. And we need to also assess the quality of the insurance and, evaluate, for example, if the patient has Medicare Advantage versus original Medicare, Part D, and other financial assistance they might need as far as co-pays. So
that's great. I love that idea. So what I want to say to people, if this is something you're like, okay, I can get it, I might want to review what we're doing at the patient level. I think what I do like, this article has a 2-page table in it. And my thought would be print it out and then take a look at the different recommendations that are coming from the patient community and from a team of people thinking about this, this for a few months to see if any of these could possibly advance what you're committed to doing there. I think that's the best thing to me. It's like, go read the table. Don't even read the whole article, just read the table and say, okay, these are barriers. And then these are different things that people are recommending, including a group of patients that would help. And if any of those are valuable for you, I just want to say that this is available. And I'm really honored that the AST has asked me to speak. And I want to thank you for your commitment to patient advocacy and engagement and activation and patient reported outcomes, because I think we're at a really exciting time where we've all cared about that forever. But now there's a sense of systematizing measurement and education and all of these things, and really including patients. And as we said, amplifying the patient voice. Is there anything anybody else wants to say on our panel?
I just want to add, it's so important to have the patient voice there, and I feel honored to represent the patients and being invited, even at the last minute, to participate in this. And that patient family advisory council concept is spreading across the country. And it really is something that's working from both sides, because the patients on these councils are working with medical professionals as part of the council itself. They are always bringing issues in, both positive and negative experiences. So from the patient side, they're bringing issues in. At the same time, from the medical staff standpoint, they provide a resource that can come in to help them. And so it's a great concept. If you haven't become familiar with it yet, its time has come. And what I was surprised at here at Penn Medicine, there was one at the hospital level, and all of a sudden the different departments are now having individual ones with patients focused on that particular concern area, be it transplant or cancer or whatever. So check it. PFAC is the acronym they use, and there's a lot going on out there.
Great.
Thank you, Amy, for this opportunity.
Oh, thank you, Jim, as usual. Thank you, Devin. Thank you to the AST and for listeners. And I hope to see some of you at AST. So if you see me, say hi. I would love to see my friends again. I miss you all. I hope you all have legs still.
Thank you to all of our speakers. I do want to mention that this program was recorded and will be made available for future reviewing in case you want to review it and any of the information presented. You may also send us a message or email us if you have additional questions for our speakers. And I can't thank all of you enough for sharing your knowledge and expertise on this very important topic.
Thank you.
Thank you, everybody.
So AST, APCOP, PSECOP, and TxAQM COP want to thank our panelists and attendees for today's session. Please remember to complete the evaluation survey and enjoy the rest of your day.